صباح الخير. اولا بشكر اللجنه المنظمه على دعوتي، دكتور بهاء ودكتور اسامه، ودايما مؤتمراتهم are so elegant. This is about the drug-induced liver disease and inflammatory bowel disease. Liver chemistry anomalies are quite common during IBD therapy. Up to 30% of IBD patients have liver chemistry abnormalities during the long-term follow-up. This is because there are various ways by which inflammatory bowel disease can be associated with liver disease, not just drug-induced liver injury, but there can be steatosis, autoimmune hepatitis, portal vein thrombosis, liver abscess, hepatitis B virus reactivation, fibrosis and cirrhosis are quite frequent to happen. Granulomatous hepatitis, amyloidosis, and hepatosplenic T-cell lymphoma can occur because of long-term immune suppression. There are also a variety of biliary disorders like primary sclerosing cholangitis, cholangiocarcinoma, and cholelithiasis can occur in these patients. Our subject is the first one, the drug-induced liver injury, but we shouldn't forget that coexisting conditions are always possible. A patient can have associated virus C, for instance. We should be aware of the terms used in this context. Drug-induced liver injury usually refers to acute conditions excluding fibrosis and nodular regenerative hyperplasia usually. Drug-induced liver disease encompasses acute and chronic insult. There is a threshold lab to diagnose drug-induced liver injury. Classically, a 5 times increase in ALT or a 2 times increase in alkaline phosphatase or a 3 times increase in ALT plus a 2 times increase in bilirubin is usually or academically used to diagnose DILI. However, the clinical context is important. If we have 2 to 3 times rise that is persistent, we should be worried about having drug-induced liver injury. Idiosyncratic injury by drugs is an unpredictable reaction relative to the pharmacological action of the causative drug, while intrinsic injury or direct injury is a predictable effect. For example, azathioprine by its mechanism of action causes bone marrow suppression. So this is a direct toxic effect. But it can produce idiosyncratically liver damage. We cannot predict this to happen. It's not in the mode of action of the drug. We usually refer to idiosyncratic drug-induced liver injury when we talk about DILI. These are the risk factors of idiosyncratic drug-induced liver injury in general, not in particular in IBD. We have the larger the dose of the drug, the more we are prone to have idiosyncrasy. When we use the drug daily, when you have the drug that is mainly eliminated by the liver, when you have a lipophilic drug, all these factors predispose a person to have a drug-induced liver injury. But we have a patient-associated factor like genetic susceptibility, age, the very young and the very old are exposed to certain drugs. For example, the young are predisposed to valproic acid, the old to INH, polypharmacy, and comorbidity. Liver, diabetes, obesity predispose a person not necessarily to drug-induced liver injury, but to a worse outcome when it happens. Azathioprine-induced hepatotoxicity, this is the most important drug that can produce DILI. It usually produces asymptomatic transit aminotransferase elevation. You should expect this in 5% of your cases. Rarely it produces more serious disorders like cholestasis, veno-occlusive disease, biliosis, hepatis, sinusoidal obstruction syndrome, and nodular regenerative hyperplasia. Of course, the last 4 occur quite late during the course of the treatment, at least 3 months from the start. How to manage such condition? Thiopurine methyltransferase activity estimation is very useful in patients taking azathioprine or methotrexate before start of treatment to prevent bone marrow toxicity. We are not sure if it will prevent also hepatic toxicity. Liver biochemistry should be monitored regularly. We should monitor them every week for the first month, then twice weekly for 3 months, then 3 monthly. Because the liver enzyme increase happened during the first phase of the treatment. Mild transaminitis, which is less than 3 times rise, usually you continue the treatment with more frequent monitoring. But if you have higher transaminitis or persistent transaminitis, we reduce the dose till it is normalized. Then we try to negotiate again the full dose slowly. Jaundice is always ominous. We shouldn't tolerate jaundice or a persistent transaminitis or a high transaminitis. We should discontinue the drug. Methotrexate is quite close to what happens with azathioprine, but macrovesicular steatosis is more common. Hepatic fibrosis can occur, and cirrhosis, as you all know, can happen with long-term use of methotrexate. It's a cumulative effect. Patients who have taken over the years 1.5 to 2 grams develop these complications. It can happen up to 14%. Actually, the incidence will vary ridiculously in the literature, but usually because it depends on the presence of associated factors, patient diabetic, obese, taking alcohol. So it varies greatly in the research. How to manage? Again, it's the same line of management as in azathioprine, but we should monitor patients who are obese and have NAFLD more frequently. And as always, as in all DILI in IBD, prognosis is generally favorable, except in patients with pre-existing liver disease who are more prone to have a worse outcome. Aminosalycilates-Induced hepatotoxicity is even milder. Hepatocellular and cholestatic enzyme abnormalities can occur as a form of hypersensitivity reaction to the sulfa component of the drug. But if it is sulfa-free aminosalicylates, as frequently used now, usually there is less systemic toxicity. The frequency is quite low, 5 per million for mesalazine and sulfasalazine. That is why we do not do routine monitoring for liver chemistry in patients receiving only aminosalicylates. Infliximab-Induced Hepatotoxicity, this is the best studied drug in this context. Increase in ALT happen in more than 6% of cases. Usually it is less than 2 times increase, so it is not of importance. It does not have sequelae, resolves spontaneously without even dose alteration. But in 1/4 of the cases, we have more than 3 times increased. And there were reports of severe cholestatic liver injury and even autoimmune hepatitis-like injury, as if infliximab had triggered an autoimmune hepatitis in these patients. That is usually reversible with discontinuation, and in a few patients it persists. Some patients had to do liver transplantation for fulminant hepatitis upon receiving infliximab. How to manage? Again, we should monitor liver enzymes during the treatment, and ALT elevation of less than 3 times. Should do more monitoring until resolution happens. If it doesn't happen, should stop the drug. If there is more than 3 times increase, or if there is jaundice, we should stop that drug. We should consider steroids based on your judgments if there is autoimmune hepatitis. The autoimmune markers can be positive in about 2/3 of cases. Liver biopsy might be needed, and in this condition, we should start using steroids. Adalimumab has the same pattern, but less frequent. And there is no, which is an important thing to know, there is no cross-reactivity known between different biologic agents. So you can shift between one agent and the other without having a more risk of idiosyncrasy on the liver. We don't have more, the patient was doomed to have DILI with one agent, he's not doomed to have DILI with other agents. This is a reminder of the hepatitis B reactivation. We all know this table. How do the frequently used immunosuppressive agents expose an individual to reactivation by hepatitis B? This red part is the worst reactivation exposure. Like, for example, we have a prednisolone of more than 20 milligrams per day for more than 4 weeks. The hepatitis B surface antigen positive have a very great risk of reactivation. Like you see here, we azathioprine and methotrexate, the risk is quite low, but the risk is moderate with infliximab, adalimumab, and other biologic agents. And we should always remember that the use of double immune suppression increases the risk greatly. So whenever you use double agents, be very careful and in the follow-up. I have 2 slides left. This is the first of them. This is a simple algorithm to how to approach DILI diagnosis in IBD. The patient presents with abnormal liver chemistry. You suspect the presence of DILI. You should look for other agents that can clinically, that helps you in the diagnosis, like skin affection, kidney injury, or if the patient has history of previous DILI episode. You can calculate the biochemical marker of the liver injury to have an idea if it is a hepatitis, mixed or cholestatic, like by this simple equation, or simply rely on which is higher, ALT or the alkaline phosphatase. Then you should search for alternative causes. Is the patient really DILI, or he has hepatitis B virus reactivation? Maybe the primary sclerosing cholangitis is there and you missed it. Maybe he developed autoimmune hepatitis, not because of a drug, but because of the association with the disease. Maybe he has other viruses like cytomegalovirus, Epstein-Barr viruses, virus C, virus A, whatever. Portal vein thrombosis may have developed. Abscesses in the liver may have developed. They happen in patients with IBD. Or a patient may have a pre-existing disease and you missed it from the start. Maybe you should revise the file of the patient or reinvestigate from the beginning. Biopsy is considered if there is negative de-challenge when you stop the drug, but the enzymes do not revert to normal, or there is chronic atypical presentation, particularly patient presenting with chronic conditions like fibrosis or vascular injuries, like sinusoidal obstruction syndrome. Also, if suspect autoimmune hepatitis, biopsy is important. In conclusion, abnormal liver chemistry is common in IBD patients. Only in some cases it is due to drug-induced liver disease. DILI in IBD is usually self-limiting. Regular monitoring for liver functions is justified in most of our IBD-treated cases. Dual therapy warrants more frequent monitoring. Therapy should be stopped if the altered chemistry is significant or it is persistent. Thank you.